This is the hepatic disorders presentation by Bree and Rachel. So to start, we're going to go over a couple of the main functions of the liver. First, it aids in digestion and metabolism via bile production, stores fat-soluble vitamins, controls cholesterol levels in your body, stores trace minerals such as iron and copper, plays a part in blood formation with the clotting factor and protein synthesis, and it breaks down old heme received from circulation into conjugated bilirubin and secretes heme back into the bloodstream for kidney or bile excretion. A few of the common hepatic disorders are cirrhosis, hepatitis, and chronic alcohol consumption. A fact that is not very fun is that over 70% of patients with chronic liver diseases also have pulmonary issues. Hepatitis can be acute or chronic and can result from virus, chemicals, drug reactions, metabolic abnormalities, autoimmune disorders, or alcohol abuse. So more on hepatitis. Some of the common pulmonary effects are fibrosing alveolitis, hepatopulmonary syndrome triad, which consists of intrapulmonary vascular dilation, chronic liver disease, and hypoxemia. Some common cardiac conditions are hypoxemia, arrhythmia, and chest pain. And some general PT implications with exercises are that dyspnea is very common. Initially, it's just on exertion, but may progress to also at rest. There's also oxygen desaturation. Cirrhosis is the most common form of liver disease in the U.S., and some of the cardiac effects are that patients typically have a circulatory system that is hyperdynamic. It typically is worse when in supine, causing an increase in heart rate and cardiac output. Plasma volume is expanded. There's a decrease in vascular resistance, and their blood pressure may be normal or it may be low. Some pulmonary effects include pleural effusion, which is found in 5 to 10% of patients, mostly on the right side. It's usually mild to moderate, but can be massive and provoke shortness of breath. And large pleural effusions are contraindication to airway clearance techniques. Ascites is also found with cirrhosis, and it's associated with a poor prognosis. 56% survive for the next 3 years, and is clinically detected when greater than 500 milliliter of fluid accumulates in the abdomen. That is then associated with weight gain and eventual peripheral edema. And finally, 2 to 10% may have POPH, which is pulmonary hypertension and portal hypertension. So this image just kind of shows that last symptom I talked about with the portal hypertension, and kind of displays some of the symptoms that are associated with that. So you can see the ascites that was talked about is on there with the fluid in the abdomen, and then just a bunch of other things throughout the entire body that can go wrong. This picture compares almost like a Venn diagram of livers, the difference between hepatitis and cirrhosis. As you can see, hepatitis is more of an inflammatory condition and has more of that pinkish color, whereas cirrhosis involves the scarring of the liver. However, they overlap because both of them produce abnormal liver functions, can lead to liver cancer, may need a liver transplant, and can ultimately lead to liver failure. This next picture also kind of shows how the liver can progress, starting with a healthy liver, into hepatitis, to cirrhosis, and eventually into liver cancer. This chart is another comparison for hepatitis and cirrhosis. However, it goes into a little bit more of the physiological details with the cellular behavior and different ways for diagnosis and causes. The third condition we're going to talk about is chronic alcohol consumption. Some of the common pulmonary effects are tuberculosis, chronic bronchitis, aspiration pneumonitis, abscesses on the lungs, alcohol cirrhosis, pulmonary complications, alcohol cardiomyopathy, pulmonary complications, and acute respiratory distress syndrome. Some of the cardiac effects include alcoholic cardiomyopathy with dilated cardiomyopathy in the U.S., cardiac arrhythmias, and systolic and diastolic dysfunction. Dilation and impaired contractility are a result of that. The liver makes a majority of blood proteins that you need to fight infection, therefore also making you more prone to infections. And chronic alcohol consumption is also associated with hypertension.
All right, so this picture just shows the progression from a healthy liver through a variety of alcoholic versions of the conditions that we talked about. So alcoholic hepatitis, alcoholic cirrhosis here. And so Sorry. So PT implications for alcoholic and non-alcoholic cirrhosis include exercise response with a blunted heart rate, decreased contraction of the myocardium, left ventricular cardiac output and ejection fraction increases, and abnormal cardiac pressure elevation. We need to prepare and take precautions with these patients by following careful hand washing technique because of their higher risk for infection. We want to avoid Valsalva because, as you saw in that picture of the man with all of the issues from the portal hypertension, they have esophageal varices, and Valsalva can lead to bleeds. And then they do, as Bree mentioned earlier, have reduced exercise capacity. An interesting fact that's a little sad, I would say, is that more men than women have alcohol-related cirrhosis, but women actually develop the disease with less and shorter exposure. Men typically need to drink 6 to 8 drinks a day for 5 years, but women only need to drink 3 to 4 days to have that outcome. So this yellow chart is out of the Goodman differential diagnosis, and I think the main things to take away from it are that if you see jaundicing, it's probably a liver condition, and patients with undiagnosed jaundice must be referred to a physician. Active intense exercises needs to be avoided when the liver is compromised. There is a decreased clotting ability when somebody has liver disease, which means the prothrombin time is increased. So a normal prothrombin time is 11.6 to 13.0 seconds. So that would be normal. So obviously you would see longer prothrombin times. A common neuro abnormality of liver failure is a flapping tremor of the hand with wrist extension. That can also happen with a few other things like pancreatic issues, but you'll see it with liver pathology as well. Here is a picture of kind of all of the different systems that are affected by acute liver failure. We don't really talk about most of these in the presentation because they're not so heart and lung oriented, but it is, I think, noteworthy that a lot of people will have like hepatic encephalopathy. I actually saw that in clinic this year, and it was interesting. So it's just something that we need to keep an eye on every system when we're starting physical therapy. All right, so cardiopulmonary implications for acute physical therapy. As I mentioned before, the liver needs that rest, so intense exercise should be avoided. Ascites can cause difficulty with breathing. A patient will be more comfortable in a high Fowler position, and a high Fowler position is the head of the bed raised 18 to 20 inches above a level position with the knees elevated. Breathing techniques can be administered for someone with ascites, and breathing techniques can help prevent atelectasis or pneumonia. Pillows and towels can be used to support the edematic patients inside lying, and positional changes must be encouraged for skin integrity. Something that we need to keep in mind, especially in the hospital, or really anytime, is if the patient is on fluid limitations, we need to not just give them, if they're NPO or if they have a water limit or fluid limit, we need to make sure to monitor that and ask the nurses about it. A study about dyspnea and respiratory muscle strength showed that patients with and without ascites report chronic dyspnea with end-stage liver failure. Respiratory muscles were weaker in the patients with ascites, and the PaCO2 was increased to a little below 4.7 kilopascals, and the arterial blood pressure, or pH, the arterial pH was decreased. So we don't usually think about PaCO2 in kilopascals, but apparently a normal kilopascal for PaCO2 is 5.1 to 5.6, and we learned it in millimeters of mercury, and a normal for that is 35 to 45 millimeters of mercury. Another thing, that's okay, slight technical difficulty. Another thing that we found was that 88% of the patients in the study reported mild to severe chronic dyspnea on a chronic dyspnea scale, so that's pretty related. Then Oops, sorry, I went a little too far. No, I don't know how to go back. We're gonna figure it out though. We're there. Sorry, we're doing it over Zoom, so it's a little complicated. Cardiopulmonary implications for subacute phase physical therapy is that, as we mentioned before, a variceal bleed can occur when hepatic blood pressure is highest, so when you have that portal hypertension. A therapist must look out for bleeds due to coughing, sneezing, and exercise, especially with patients with cirrhosis. A therapist can teach avoidance of the Valsalva maneuver so we can do the breathing out type of breath work when you're doing something hard instead of holding your breath. And we can look out for things like slipper wearing and unlaced shoes in home health. That will help us kind of monitor if they're having fluid buildup. And just a note, fluid buildup can increase blood pressure. On the right here is a picture of what can happen to the veins when you basically you can get varicose veins when the portal hypertension increases, so that might happen to your patients as well. Cardiopulmonary implications for chronic phase physical therapy are that you need to know that symptoms are likely going to be in the more extreme phases. There is very limited exercise at this time before you get to dyspnea. And then the cardiac pressure elevations increase heart rate and decrease oxygen consumption. So you need to avoid the supine position for patients with non-alcoholic cirrhosis, as it may aggravate their symptoms. Patients are at risk for osteoporosis, especially if they had cirrhosis. Posture may be impaired due to this osteoporosis, so it might be actually a way to catch the osteoporosis. Muscle performance might be impaired in alcoholic myopathy. And PT should focus on fall prevention because obviously osteoporosis is going to, negatively impact outcomes if they fall. And then we already mentioned, but it should be kept in mind that these patients will have impaired aerobic capacity and they will have edema on their feet and hands. So these are our references for you to look at as you please.